Hi, I'm Dr. Nadege Gunn. I'm a gastroenterologist and hepatologist in Waco, Texas. And today I want to quickly talk about the practical approaches to PBC, primary biliary cholangitis, and its clinical management. So what is PBC? Well, essentially, it's a chronic autoimmune liver disease that aims to destroy the small bile ducts. It occurs primarily in women. So of those affected with PBC, we expect about 92% to be women. It can affect men too. And oftentimes when men are affected, it's more aggressive and it presents a lot later. But it's very important to diagnose PBC early because if you don't, the bile ducts continue to be destroyed. Inflammation starts to affect the liver, and then ultimately the liver starts to scar. And the end result can be cirrhosis, which, as we know, once you develop cirrhosis, the liver has the chance of failing, requiring liver transplantation. So we need to diagnose this early and personalize the management. So how is this diagnosed? Well, it's really simple, and most people can be diagnosed with blood-based tests alone. So those key blood tests are the alkaline phosphatase and the antimitochondrial antibody. So the diagnostic criteria is to have at least 2 out of 3 specific things, either an elevated alkaline phosphatase, an elevated antimitochondrial antibody, or a biopsy that shows the small characteristic histological signs. You don't need all 3 of those things. You need 2 out of the 3. So if you have an individual who has an elevated alk phos and an abnormal antimitochondrial antibody, that's all you need, 2 out of 3. But say you only have an elevated alk phos and you don't have an AMA that's positive, then maybe the biopsy is going to be what gets you the diagnosis. There are also some antibodies that you can also look to see if your local lab has, and that's the GP210 and the SP100, which can be positive in those who have AMA negativity. So that might be a way for you to maybe not proceed with biopsy if you can get these other autoantibodies to be positive in addition to the alkaline phosphatase. So those are your tools to identify who has primary biliary cholangitis. And then you often want to know where they stand when it comes to fibrosis. So there are a number of tools. One of my favorites is elastography, where you non-invasively can measure the stiffness of the liver and know where your patient stands on a fibrosis standpoint. Now, when we've identified our patient, we've diagnosed them, and we've risk stratified them for fibrosis stage, then we get into treatment. And the main first-line therapy is ursodeoxycholic acid, or UDCA, urso. It's dosed at anywhere between 13 to 15 milligrams per kilogram daily. And you monitor their response. And that response is really normalizing the alkaline phosphatase, getting it down. We used to be of the belief that it's 1.67 times the upper limit of normal for the alk phos was a great goal. But now we're learning that normalization is the way to go, and you want to see that alkaline phosphatase normalize. The issue is that ursodeoxycholic acid in about 30% of patients is not effective, or it doesn't get you to normal, or the patients don't tolerate it. And we really, at a certain point in the history of this disease, didn't have great or any second-line therapies. But one of the second-line therapies that we do have available is obeticholic acid that came out in 2016. It's an FXR agonist that can help add a little bit to the urso to lower the alk phos. There has been some recent concern about this drug, about its effectiveness and safety. And so you may find in current literature that it's being debated whether it's to stay on the market. But 2024 did bring some promising second-line therapies, which are both PPAR mechanism drugs, which can help to lower the alk phos more, even has some effectiveness in itching, in reducing itching. And so we have some great second lines that we can offer patients who either cannot take urso or are intolerant to it or are not achieving that goal of lowering the alk phos to normal. So we're really excited about emerging strategies for our patients. More drug mechanisms are being developed to help with some of the complications related to PBC, to include the itching. Hopefully, we'll start to see some more drugs that come around to help the overall quality of life for our patients with PBC. But it is an exciting time because we have multiple second-line therapies available and a great first-line therapy, and hopefully more to help with symptom management. So in closing, I'd like to emphasize that we want to be proactive in diagnosing PBC. We want to individualize the care, essentially making sure that we are assessing for fibrosis, because we know that close to 50% of patients who are diagnosed even early, within 5 years, will progress to advanced disease. We want to integrate these new therapies, making sure that we give our patients the best option to normalize the alk phos so that we can prevent progression of disease, consequences and complications downstream of this disease, and ensure our patients have long-lasting and healthy lives. Thank you.